Hey everyone, welcome to the first online CC training. This one is going to be used for January 2019, and it's also going to be part of the new CC orientation, which will take place partially online. So we're going to be covering a lot of stuff as far as ventilator basics in this one, and then more advanced ventilator stuff as well. So for current employees, some of this stuff might be a little bit repetitive, but it's still a good refresher, and then for new people, this will be a lot of new information. So just starting off with the basics outside of the ventilator, there's going to be these two limbs right here. So the inspiratory and expiratory circuit limbs. They are identical and interchangeable. However, the circuit itself comes with a water trap on one side, and you're going to want to attach that to the expiratory limb. The next thing is that there's these two sensing limbs, and one is male fitted, one is female fitted. They can only go in one way, and so those are easy to hook up. This is a really common site of ventilator circuit failures. So if things aren't attached tightly, then you're going to get a leak and it's going to tell you the circuit is failing. On the other side of the ventilator, we have this high pressure oxygen tubing, or oxygen hose, and that green hose should always be attached over here. It's a threaded attachment. And then right below that, there is a nebulizer port. And so what you'd normally attach to the wall would actually get attached to this nebulizer port, and for that to work, it has to have that high pressure fitting on there because it diverts some of the gas flow in order to power the nebulizer. This ventilator can also do a low pressure setting by turning, once we get into the actual screen, you can turn the FiO2 down past 21%, and that will give you a low pressure source setting. For that you'll need our distal FiO2 sensor, which we'll talk about later. And then you'll be using, instead of that green hose, you'll be using just a regular piece of oxygen tubing, and then you'll need one of those green Christmas trees to thread on there. So this will include some videos in here. I've worked them into the different slides. So here's just basically how to turn it on. So you arrive at the ventilator, bottom left button over here is going to turn this ventilator on. Now, there's a few different options here. Same patient, new patient, and vent setup. If you were to go into vent setup and then EST, that would be how we would test our circuit. But for now, we're just going to go into new patient. It'll ask you for a patient ID, just ignore that. And then we'll come down to patient size. And it's pediatric and adult. For most of our patients, obviously we'll want over 40 kilograms, so the adult. And then we'll hit next, and then it's intubated or non-invasive. So we'll just do intubated. And it'll come up with some really basic settings right there. Tidal volume of 500, 12 breaths a minute, PEEP of 6, FiO2 21, flow trigger 2 liters a minute, I time of 1, and an IDE ratio of 1 to 2. So most people can be safely ventilated on that. That's obviously not what we leave them on, but it's just some very basic settings just to get you started to hook up to somebody. Mostly if you're using it for pre-hospital use, you can just turn it on, attach it to a patient, and then within the matter of a few seconds, adjust their settings. So once we turn it on, so this is like before we would ever bring it to a patient bedside or wherever, maybe ditch side. So when you turn this thing on, we have to do what's called a circuit test, and this is something that we do before we put the ventilator away every single time. So whether it sits at your station or it's on your actual ambulance, we test these circuits. And so this is that thing that we kind of got a preview of in the last video, where turned it on, hit vent setup at the all the way bottom, went into EST, and then you're going to hit start, and we'll see this is called testing a circuit. This is you want to make sure everything is really tight on here. So we're at the beginning screen, vent setup. It'll warn you to remove the patient. So we'll cancel that alarm and go back. Extended system test, or EST. And it'll say remove patient, and all you do is hit start right there, and it's gonna ramp up the flow. And then what you do once it's ramped all the way up, it'll tell you to occlude Y. Put your finger over that and don't take it off until the test is finished. So it says passed, and then it stops. Then you're good to take your finger off of there. And then we'll go over how to store the ventilator for use for the next time. So to actually turn a ventilator off, we'll go over standby first. So to put it in standby, there's a tab up there that says standby. It'll ask you to confirm. You can hit yes. But to actually turn it off, you have to hit resume ventilation. It will not let you turn it off in standby. So you'll put it back to this normal screen where it's ventilating and hold the power button. all ventilators will start alarming, and so you'll need to hit the alarm button. So this is how the ventilators are actually stored. So you can see that green hose is on the left side. That can be coiled up, usually like right on top of the screen as well. That makes it a little bit easier to carry. So the green hose is coiled up. You should always have a carabiner on it for use to hook to the back of the cot. And then a filter should be somewhere on the expiratory limb. So remember that top limb, that top thick limb is the expiratory limb. It can be right at the ventilator. It can be on the expiratory side of the Y. Just never put it after the Y. And you might think, oh, why not? It seems, especially if it's an HMEF, it seems like a good place for it. That'll really increase your dead space. And so if you do end up putting one there, you have to increase your tidal volume. So you don't want to have to increase your tidal volume just to make up for a spacer. And so keep it on the expiratory limb. And then the end tidal CO2 does go between the patient and the Y because you want a good reading. And so that should go before the elbow. And so it should go between the Y and the elbow. And then once all that stuff is set up, you can take either the blue cap or the test lung and put it on the end of there. That's to keep the circuit closed and keep it clean. And then you'll want to just throw a couple pieces of tape on here, otherwise it'll be really hard to carry around. It makes a world of difference whether or not you put just a few pieces of tape on there to keep the end tidal CO2, the sensing lines, and the limbs together. If you don't do that, the person after you will probably want to kill you. So here's the ventilator all set up. This is how the back of the cot should look, or something very, very similar to this, walking into a critical care scene. So you should have a 12 lead prepped with the stickers already on there, an SpO2 with you, and the monitor screen visible. Looking at the back here, the oxygen is already attached, and the vent is secured. Over here, you should always have one of these securing devices on the IV pole side of the cot, and then the end tidal CO2 is attached down here on the bottom left as well. So everything is ready to go. So looking at the actual interface of the ventilator itself, like we saw before, the on-off button is over on the left. You can click a button to display the alarms. That'll turn the screen a bunch of funny colors. If you hold that battery power check button up on the top right hand side of the screen, it'll tell you the actual percent of the battery. Scroll knob is used all the time. You can do a control lock where it won't allow anything to bump into the screen and change the settings. You can give a manual breath. Maneuvers button is going to be really helpful when we talk about taking plateau pressures. And then the alarm silence button is over there opposite of the on-off button. How we do things in here is tap, turn, confirm. So basically once you tap a setting, so let's say we're changing the FiO2, you're going to tap FiO2, you'll turn it either up or down, and then go back and hit the FiO2 again as just an example. Otherwise, if let's say you just tapped the FiO2, scrolled, and then tapped onto another setting, it wouldn't save what you did. So tap, turn, and confirm. Once you're into the actual ventilator, these are the two screens. There's a monitor screen and the control page that most people will start to look at, and then we'll see what we monitor in graphics. So this monitoring page is just going to show you all of your different alarm settings. So like when you look at rate, for example, the patient's currently ventilating at a rate of 12, and then you can see that there's a top bar, and that top bar says 40. It's going to alarm if the patient breathes above 40, and it's going to alarm if the patient breathes below 10. And so look at the P peak next to it, for example. 35 is the current peak pressure. It's going to alarm if it goes to 40, and it's going to alarm if it goes below 10. So that's what that means. And you can also click on those and change which ones you want to see. On the very top left is the airway pressure. That's going to be a live graph that we'll look at in a little bit. And then the top right will show you your most recent alarm. If the alarm is blinking, it means it's current. If it's solid, it means that it's passed by. And then there's the control page down below. This is where you're going to set your rate, your tidal volume. If you're in a pressure mode, inspiratory pressure and PSV, your PEEP, your inspiratory time on the bottom left there controls your I time. So it controls three things. It controls your I time itself in actual seconds. And then there's an I to E ratio, so how much time you spend on inhalation versus exhalation. And then right below that, where it says 40, that's going to be your liters per minute. And our ventilator references do reference the liter flow per minute, so you'll want to know where all that stuff is. Decreasing the inspiratory time obviously increases the flow. and it will lengthen your IDE ratio and vice versa. You make the inspiratory time longer, you'll have a shorter IDE ratio, and the flow will be slower. Inspiratory pause is next to that. We'd only use that usually in inverse IDE ratios if we really needed to extend it or hold at a certain pressure. Pressure trigger after that, we'll talk about how that pressure trigger works with this ventilator. Bias flow is also located in that flow trigger zone, so remember that part. And then FiO2 is right there. And you can see that when I was talking about low pressure sources before, where it says LPS all the way at the bottom left hand side of FiO2, when you turn it past 21%, you're going to get that low pressure source setting. And then conversely, it goes to 100% if you spin it all the way over to 100%. So here is going to be where you make the changes. Right here is going to be all of the graphics, and so that's where you're going to mostly want to monitor. You only want to stay in this main page to click in a few settings, and then you want to get out of it. You don't want to stay in here because it doesn't tell you anything besides what you're currently at, which is really what your monitor page is up top for. And you can find out most of that information in the graphics section. It'll tell you a lot more as well. We'll take a look at it in a second. And then maneuvers are right here. Every single time that you change a tidal volume, change a setting, there's a change in patient condition, you want to take something called a plateau pressure, and we'll look at that in a minute. So first we'll look at the monitoring page, which is right here. So most people choose to look at this in the waves form. If you know how to use flow volume loops, those are probably better, but not many paramedics are familiar with those. So we'll look at the waves for now. So we'll look at this top one first, not the one the finger is pointing at, but above it. So it's going to be flow in right here. And so when you're above that line where it says 0 is 0 flow per minute, 0 liters of flow per minute. So flow in is up here, and it stops right there. So that whole hump up is going to be flow in, and then this like triangle shape coming down is fast flow out, and then kind of coming to 0 flow. And that 0 flow ends pretty much right here. And then this flat line right here is no flow, a no flow state. And that's really important to note because you always want a little bit of a no flow state before the next breath comes, because let's take a look at what would happen here. So if we had, like, follow that dotted line, and if we can see right there how there's this elbow, and the next breath would have started, like let's just imagine that's the solid line, and the next breath started, flow started to come in before flow stopped going out. Well, that is the definition of air trapping and auto PEEP. And so even if the patient doesn't have like bronchitis or emphysema or asthma, you can give them auto PEEP by setting their ventilator wrong, by giving them a breath before they can exhale. And so what do you do to correct this? You increase the flow, or otherwise decrease the I time, which increases the IDE ratio. So like instead of like 1 to 2, maybe you go to 1 to 3 or 1 to 4. Or you can decrease the respiratory rate, because that's going to move that next breath out further, but just make sure that you're getting the same tidal or the same minute volume. So remember, if you go down on your rate, you have to compensate with a little bit more volume. Here's that monitoring graphics wave. So as we look at this wave, you can auto scale these if they're off the charts. When you click on the actual waves themselves, you can choose to color in different portions. So here's the inhalation portion, and then here's the exhalation portion colored in like this, and that little box will show you which one it's going to fill with color. I prefer to have it set like this. I think of the red as exhalation. You can color that if you want, but it's really easy to see when you set that exhalation to a color when it actually has met baseline and disappears. And then I come down here and I change my airway pressure waveform to something that's opposite, so that it's easy to tell when the patient inhales and when the patient exhales. So this is what you should always be monitoring in. So as far as that next portion, we talked about maneuvers. So here's how you get there. You're going to be in this main screen, and you'll see me hit maneuvers in a second, and I'll walk you through how to check a plateau pressure. Obviously, we keep our plateau pressures below 30. We'll talk about how to adjust that in a minute, but that number 30 is very, very important. Otherwise, we're at pretty high risk of causing ARDS. And then driving pressure is even more important, and we get that number from our driving or from our plateau pressure. So how do we do that? So a driving pressure is going to be our plateau pressure minus our PEEP. So let's take a look at how we're going to figure that out. So like I said before, we can go to our graphics, that's where we're monitoring. One more over is going to be our maneuvers, and there's going to be this thing called arm right here. And we see P-plat down here, the button up on the top right of the control screen. That is going to arm this, and there's this little maneuvers button down here. And what you're going to do is you're just going to hold that, start holding it at any time. It'll do the next breath, and hold it for just 1 to 2 seconds, and it'll give you a static pressure. And make sure you have a nice straight plateau like that. So it came back at 18. And so when we come back here and look at our PEEP was 6. And so I've got 6 and 18. So what is my driving pressure? If I were to subtract my P-plat, or subtract my PEEP from my P-plat, it would be a driving pressure of 12. Now that number is really important. It is very significant with ARDS. If you have a driving pressure that's over 15, then you are actively murdering that patient's lungs. It's very, very dangerous. So you want to either increase your PEEP to see if you can recruit more lung, or you're going to have to go down on your tidal volume so that you're not ripping apart their lungs so hard. So I'll just quickly go through the presets that this ventilator does when you first turn it on. So this is only for the adult sections here. So bias flow, which we'll talk about in a little bit, that's going to be the flow that comes in the inspiratory, out the expiratory at all times, independent of what the patient moves. That's basically what keeps the ventilator limb from turning into a giant snorkel. It gets rid of the CO2 so that we don't have so much dead space. So it'll default to 5 liters a minute. FiO2 is going to default to 21%, so you'll usually have to change that. Flow cycle is going to be off. Flow trigger, the flow that they have to generate inwards, the speed of the flow, is going to be set to 2. It has an increase oxygen setting, so like if you're going to change circuits or something like that, then you can hit the increase oxygen button, and for 3 minutes it'll add 79%. So what does that mean? If you're at 21%, it adds 79%. It will ventilate them for 3 minutes at 100% oxygen to up their saturation, so that if you're going to be suctioning or you're going to be changing out a vent circuit or something like that, then they can be saturated for that time. Inspiratory pause will be off. Inspiratory pressure, so like if you are ventilating in like pressure AC or something like that, it'll be set to 15 when you first turn it on. Inspiratory rise, we'll talk about that later, it's going to be set to 4. Inspiratory time, 1. You always want leak compensation on, and it'll default to volume AC when you turn it on. For non-invasive settings, so these are like the CPAP, BiPAP settings, then you are going to have a PEEP of 6, pressure trigger of 3, so they have to, well actually that's the same as the invasive. PSV, or pressure support ventilation, will default to 10. PSV cycle, that means when there's 25% of the flow left, it will cancel the cycle. PSV rise is 4. PSV time max, this is like the max time that it will allow the vent to assist them, is 2 seconds. So that's time max of pressure support ventilation. Rate of 12, this is like the apnea backup mode. And then don't worry about any of the SBT settings. That SBT setting means a spontaneous breathing trial. That would be for like ICUs and things like that, where they're trying to figure out if the patient can be extubated. They'll put them on a spontaneous breathing trial because this is an ICU ventilator. So we don't worry about that mode too much. So that's going to end section 1, and I'll see you guys in section 2. Okay, this is going to be section 2. Let's look at making some basic changes. So first we're going to look at modes. We've got the ventilator in standby here. We'll take it out. And what we're going to notice here is that changing the mode is one thing that's different, because it's not tap, turn, confirm. Changing the mode is pretty serious, and so what you're going to have to do here is, once you select the mode that you want to be in, so let's say we want to be in volume AC, we don't select the actual button again. There's a flashing button that says accept, and that's how you're going to change the actual mode, because you don't want to end up in the wrong mode the same way that you change any other setting. So we'll look at changing the tidal volume here. So this is one of the first things where you're going to look at one of the resources that we use. And this is the updated resource. And so you'll look on here and everything goes based off of ideal body weights. What does that mean? It means how tall are they? Because that's what it's going to determine the size of their lungs. If anybody ever tells you that, oh, the patient is, 150 kilograms and, they're going to need a really big tidal volume, that's not true at all. You might need a little bit more pressure to ventilate them because there's a lot of transthoracic pressure from their body weight. But that doesn't mean, just because a 5'5" person gains 300 pounds of body fat, that does not make their lungs any bigger. It actually makes them smaller. So they don't get a huge tidal volume. It all goes by actual height. So you're going to look at, is it a male or a female? So let's say that we have a female. And then once you know the sex, you're going to come down here and we'll say maybe it's, a 5'7" female. And we come down here and we say, how many cc's per kilogram are we going to use? We'll go into how to determine that later, but maybe 6 or 7. So let's just go with 6. And it says about 370. So we can do 370, 375, anywhere right in that ballpark. And what's really going to determine is that tidal volume safe is going to be their plateau pressure and their driving pressure. And then right below it, you'll see that there is a recommended frequency, and that's a bottom line respiratory rate. On ventilators, in ventilator speak, it's a respiratory rate is often referred to as a frequency. So why is that 20? There's a certain calculation that we do that's listed on the other side of this resource, and you're going to see that those are like the basement numbers. So to move that small of a tidal volume, you need to move it this many times per minute to make an average minute volume for that patient. So it gives you your starting respiratory rate and tidal volume right there, just based off of their height and sex. And so we'll make one of those changes real quick, and we'll put it in this person. So we've got it at 500, so now we're going to come down here, and we're going to say, turn that all the way down to 370, and then tap to confirm it. So it's tap, turn, and then confirm. So then we found out that our frequency, we'll zoom in on that box, was 370 right here. And so what we're going to do is we're just going to pretty much repeat that same sequence. We're going to tap it, and then notice what happens with the IDE. Look at it, as I'm going up on the respiratory rate, the IDE ratio is becoming shorter. So I went from 1 to 4 or whatever it was, and increased the respiratory rate to 20. And now, without changing the I time or directly changing the IDE ratio, because I was putting those breaths closer together, it went from a 1 to 4 to a 1 to 2. So you always have to check and make sure that your IDE ratios are okay after you put in the respiratory rate, because that changes. That's one of the things that majorly changes your IDE ratio. So let's look at FiO2 next. FiO2 is on the bottom right, and we're going to be using this scale right here. So this is mostly meant for what we call lung injury patients, who would be anybody basically that doesn't have COPD, asthma. And you can see that it's pretty generous with the PEEP. And so before you ever leave, 40% FiO2, you should be leaving 5 of PEEP. And this is because most of the time when we have a hypoxic patient, they have a lot of atelectasis going on because they haven't been naturally sighing, they haven't been using negative pressure ventilation for themselves to open their lungs up. And so we ventilate very small portions of the lungs, and that creates a ventilation and perfusion mismatch, or a VQ mismatch. And so the use of PEEP expands the lungs so that we have more surface area for gas exchange. And a lot of times increasing the PEEP by itself can fix an FiO2, or can fix an SpO2 without even touching the FiO2. So your goal is 94 to 99%. Obviously, we never want 100% because then we have no idea what the PaO2 is on the blood gas, because that can get sky high. So there is an asterisk down below, and we'll get to that in a second. So you can just see that these things are increased in tandem. So if you had like 40% and 5, maybe then you'd have 50% and 8, and 60% and 10. And so that can go all the way up until you're using pretty high PEEP and FiO2. With patients that have asthma, bronchitis, emphysema, you're going to have different levels of PEEP. So if you have somebody with like asthma and bronchitis, they probably self-PEEP quite a bit. And so you might go more generous on the FiO2 on them and lower on the PEEP. On the other hand, even though emphysema is also a COPD patient, you might be more generous on the PEEP with them because they lose a lot of elasticity in their lungs, and so they need PEEP to keep it open. I always think about an emphysema patient's lungs as being kind of like shopping bags. Like they can expand and contract, but they have like real no elasticity to them. They kind of just stay in the form that you crumple them up into. And so they need PEEP to keep those open because they have very low elasticity. And then lastly, it says monitor the mean arterial pressure in hypovolemia. If they have relative or absolute hypovolemia, patients can get a little bit hypotensive on PEEP, and it's not nearly as exaggerated as people think it is, but it is something to watch if you're using PEEPs over 12, 14, 16. Really a PEEP between 5, 8, 10. That's really not very much, even though we don't see it very common. But using PEEP is part of a lung protective strategy that a lot of hospitals haven't caught on to yet. And so you'll frequently find patients that are on 5 of PEEP and 100% oxygen to try to keep them oxygenated, and that they have not even thought about trying to increase the PEEP to increase the oxygenation, but they go hand in hand. There used to be ventilators out there that actually the FiO2 and PEEP were one dial. You couldn't increase one without the other. That's how closely related they are. So when you come in here, you're going to see that you're going to have that oxygen connected, but it's not connected here, so you can see the O2 inlet pressure is nothing. So when I go to turn up the oxygen here, and I grab this FiO2, and I turn it up past room air, it's going to know that there's nothing coming in right now. Because there's no pressure coming in the O2 inlet. And so I'm going to turn that back down to 21%. It's going to stop drawing oxygen. And then you can see the loss of O2 alarm is no longer current, and I can get rid of that. So make sure that oxygen is connected, and make sure you're reading O2 inlet pressures so that it can actually suck in the oxygen. Here's the I to E ratio. So there is a portion on this, and it's called comfort, and that's for a reason. Faster flow rates are one of the biggest things that can reduce your need for sedation in a patient. If the patient feels like they're getting a really slow flow from the ventilator, then they're going to feel like they can't take the breath in like they want to. And so when I have a patient that's guppy breathing, that looks air hungry, that it is difficult to sedate, one of the first things that I do is I go to the ventilator and I'll turn down the I time so that they get the breath faster, because they can feel like they're suffocating if you don't do that for them. So you can see that this is for flow rate. It says set to 60 to 80 liters per minute. And then for injury patients, it can be an ID ratio like 1 to 2 or 1 to 3. Really the ratio is what you're going after, but then you want to pay attention to the actual flow rate if the patient is having difficulty with sedation. If the patient is not oxygenating well, we'll consider those inverse IDE ratios in a minute here. So you come down here, and we're going to notice that as you change the I time in seconds, that the flow rate is going to get faster. So 33, 37, 42 liters a minute, 49 liters per minute, 58. So it can get pretty fast down here. And then once you get the ID ratio that you want, so let's say I wanted a 1 to 4 for obstructive patients, then that's what's going to allow me to set that ID ratio. And what I'm looking for there is no air trapping. So that bottom red one is reaching baseline, or that top red one is reaching baseline, so that I'm not air trapping at all. We'll look at a different one here. So this is going to be inverse IDE ratio. So this would be like if the patient, we have them on a lot of FiO2, a lot of PEEP, and we just can't oxygenate this patient. And you're thinking, well, I've got the oxygen turned up all the way to 100%. I've got them on a really high PEEP. Like, what am I supposed to do next? Well, you have to actually think about how long you're spending on oxygenation and how long you're spending on ventilation. So in the respiratory cycle, inhalation is oxygenation and exhalation is CO2 elimination. And so what you're going to do here is you're going to flip the IDE ratio. So in this example, we're going to be in a 1 to 2 IDE ratio. And what we're going to do is we're going to flip this to a 2 to 1 IDE ratio. So that means I'm going to be spending twice as long on inhalation as I am on exhalation. And you're going to see that I'm going to run into a little bit of air trapping when I do that. So I'll have to lower my respiratory rate to allow them adequate time to exhale so that they don't air trap. And yes, these patients are probably going to get a buildup of CO2. So this is called permissive hypercapnia. The end-tidal CO2 is going to rise on this, but when it comes to SpO2 versus end-tidal CO2, the SpO2 always wins. They'll tolerate some hypercapnia, they'll tolerate a respiratory acidosis. They will not tolerate a hypoxia. That is what causes cell death, but they will tolerate some acidosis. So we'll take a look here. So I'm at a 1 to 2 right now, and what I'm going to do is I'm just going to turn that. I'm going to pay really close attention to, oh, there it goes. I'm at like a 1 to 1. Now I'm at a 1 to 1, 1.3, 1.5 to 1, 1.71. So there's my 2.0 to 1. So twice as long inhalation as exhalation. And you're going to see I check my flow waveforms here, and it looks like I have some air trapping. So that's a problem. I don't want to air trap this patient. That's going to make their acidosis even worse if they can't exhale. So I've got to go down on my rate. And you can see as I'm going down on the rate, it's changing my I to E ratio. So now I'm at like a 1 to 1. But I'm still spending 2 seconds on inhalation, which is what I wanted. So it looks like I have some free time there where it's at a no flow state, so I'm going to turn the respiratory rate up a little bit. And this looks like it's pretty decently set in. Getting a full exhalation, but minimal downtime, but I'm still getting a really long inhalation. And just like it says there at the bottom of that card, it says this will cause CO2 retention and difficulty with sedation. Deep sedation, then paralytics may be needed. So patients will not tolerate this very well. Patients don't tolerate hypercarbia very well. They don't tolerate slow eye times very well. And so these patients do usually need deep sedation. So that would mean probably if you're using ketamine, a total disassociation state. If you're using propofol, probably heavier uses of fentanyl on top of it. Watch their heart rate for signs of low sedation, and then probably paralyzing them so that they're not interrupting this respiratory cycle. This would be an example, staying on the flow waveform things here. This would be an example of a patient who is, we put them on the vent, we put them on 1 to 2 I to E ratio like normal, and it turns out they have like some bronchitis, some emphysema, some asthma, and they're air trapping, as you can see in here. So they have that step off. So they're still exhaling, that red bar up above, and it doesn't reach baseline before the next flow comes in. And so here's what we're going to do. We've identified that they're air trapping. This is not good. They're holding pressure inside their lungs. And so what we're going to do is we're going to come out here and hit main so we can make some changes. And we're going to change that 1 to 2 I to E ratio to a 1 to 4 I to E ratio. So I'm turning the time down. Now I've got a 1 to 4, and I'm going to check it again. And we're going to see what we have here. So it got a little bit better, but definitely did not reach baseline. So I still have some work to do. I've identified that they're still air trapping. So now I'm going to go down on my rate, maybe by like 1, 2, 3, and that's getting really close. So moving those next breaths out further, that's getting really close. Let's go down by another 2, and then we'll check it again. I'm at a 1 to 5.3 I to E ratio right now. And it turns out that's pretty much what this patient needed. Because they needed a 1 to 5.3, so I had to move that next breath out longer and increase the flow so that the breath came in faster as well. So remember that always monitor in that flow waveform. Moving on to trigger is the next thing. Trigger is going to be found right here, and its default set to 2 liters per minute. We'll talk about what that means in a minute. As you increase the flow trigger, so say like 4 liters per minute, that's going to make it less sensitive to give a breath. If you moved it down to like 1, that would be really sensitive. And then your bias flow, which is closely related to a flow trigger, is found in here as well. So like when you go to give a nebulizer, which you can see the nebulizer tab right above mode there, if you go to give a nebulizer, it won't let you unless the bias flow is set to 10, and that's how you get to the bias flow. Is you go to flow trigger and then tap in the sub menu down below it, bias flow, and you're going to turn that up to 10. So what does that actually mean? So on the picture on the right here, we can see like the end of a limb. So we're coming up to the Y port here, and this ventilator has this thing called bias flow, and that's what, like I mentioned before, that's what keeps this ventilator circuit from being one gigantic snorkel. So it's what washes away CO2 so that the patient doesn't breathe it. So basically, if you see that first sensing hose right there, the one on top of the yellow one, that is the end of the dead space. And what everything before that, so like where my green arrow is coming in, to this arrow right here, to this arrow right here, is called circulating dead space. And it's not really true dead space because it's got a continuous flow that goes through it to wash away CO2, which is called the bias flow. It's normally set to 5 liters per minute. And so what that means is that independent of the patient breathing, never mind whatever the patient is doing, that ventilator is always sending 5 liters in one side of the circuit and out the other side of the circuit. And so, we need to turn that up to 10 when we have a nebulizer attached. So what is the flow trigger? So a flow trigger senses that distal sensing limb, that one that's clear, not yellow. That one will actually sense when the patient diverts 2 liters per minute of flow. So out of that, let's say we got 10 circulating around in there. When the patient diverts 2 liters per minute of that flow, the patient will have then triggered the ventilator. So that's what the 2 liter per minute trigger is. And that's what will actually trigger the patient, or trigger the vent to give the patient a breath. So I have seen it before, like let's say you have a very morbidly obese patient and you're bumping down the road in the ambulance. If this trigger is set too low, so let's say that they have a lot of weight on their chest, and when you hit bumps, their chest bounces up and down quite a bit, they may inadvertently trigger the ventilator, even though you don't want them to and they don't want to. They're just bouncing. And so you may need to turn this trigger up to 4 liters a minute. Or what you can do is you can go in, and if you turn it all the way down, you can turn it to a pressure trigger and then turn the pressure trigger up, and then it will sense negative or relatively negative pressure versus the PEEP, and that's what will cause the ventilator to give a breath. But this can be a huge problem if you don't know how to fix it. If you have a patient that's inadvertently triggering, or if something is leaning up against your ventilator tubing, like you've tucked it somewhere, and the patient's arm is resting up against it and bouncing or something like that, it can cause an accidental flow trigger or pressure trigger, and it can be continuously cycling and hyperventilating the patient and breath stacking and all this stuff if you're not watching it carefully. The next thing is airway pressure. So PAW is airway pressure, airway P pressure, and then the mean pressure in the airway. And so the airway pressure is pretty much like a live measurement, and then the P mean is like it's the average of that pressure. And so we'll look at it up here at the top left-hand side of the ventilator. So you can see it says airway pressure right there in centimeters of water pressure, and it's going up to like 18. You can see your P peak right there, and then P mean is down by the left side. So over the course of a minute, the average pressure is like 9 all the time. So the next thing to look at here is the P peak, and this is what people really spend a lot of time thinking about, especially in the respiratory world. They're always asking what the peak pressures are. It can signal airway resistance. It can signal that the patient is under sedated. It can signal vent asynchrony and things like that. So when we look at our ventilator, we can see that it's set to 40 right now. So if you see the P peak, it says the current one is like 17. And then the ventilator alarm, the P peak, is set to 40. And on this ventilator, you can see that there's a little triangle right on top of 40. And so we're going to adjust the P peak and watch how that triangle moves. The P peak is important because, like, if the patient, let's say they get like a mucus plug or something, if the P peak is going over the set alarm limit, the ventilator will cancel the breath. And so with this one, let's say the patient had a lot of airway resistance, they had asthma or something, the vent will try to give a breath, but it'll cancel out when it hits that alarm limit. It won't go over that pressure limit that you have it set to. And so what I'm going to do in this video is I'm going to take the P peak and I'm going to put it underneath what the ventilator is hitting for a peak, the alarm limit. And you're going to see that triangle move all the way down, and then the vent will not ventilate over the set limit that I have. So I'll click that top part, and I'm going to keep moving it down. I'm going to move it below what it's doing. So it's going to 18 right now. I'm going to set it to 14, and it's going to start freaking out, and then it will not ventilate over that amount. It'll cancel out as soon as it gets there. So that's your P peak. So moving on to inspiratory pressure. So this is one that's going to be available if you are using a pressure AC mode or any kind of pressure mode. Usually this is going to be available. So our vent, it's very important to note this, our vent is what's called additive. And so when I look at peak airway pressures, it's going to be PEEP plus either inspiratory pressure or pressure support ventilation, which is PSV. So let's take a look at how that works. So right now I have my inspiratory pressure set to 20. I'm in pressure AC right now, and I'll look at my airway pressure. And it's interesting to note that it's going up to like right about 20. It's got some other resistance in there. It's going to 21. So pretty much exactly what I have my inspiratory pressure set to. But if I go in here and I dial my PEEP into 5, look at what happens to my PEEP peak. It went up exactly 5. So there's a baseline pressure and then there's the pressure on top of it. And so that kind of looks like this. If you look at my illustration that I have over here on the right side of the screen, when I look at inspiratory pressure set to 20, I got PEEP set to 0. That means my airway pressure up top, that's kind of signaling like what my PEEP peak is. When I go like this and I change PEEP to 5, here's what's going to happen, is I'm going to add a baseline pressure and then it's going to go up to about 25. The other thing to look at here is PSV, which is pressure support ventilation. And this graph kind of signals two things. It's going to represent in pressure, but really this is like flow and volume coming in. This is like pressure and volume, a pressure volume loop or a pressure volume wave. And so over here on the y-axis, we're going to have pressures. So here's 5, 10, 15, 20, 25, and then we'll put some settings down here. And we'll say the patient's getting ventilated at a rate of 20, and we have them in like, this mode would pretty much be like pressure SimV. And so I know that every single time, every single minute, this patient will get a minimum of 20 breaths a minute and an inspiratory pressure of 20. So there's no tidal volume in here because we're in a pressure control mode. So that would be like these ones right here, these white ones. I know that I'm going to get 20 of those per minute. Those are constant. They'll be the same every single time. Our tidal volume will not be able to be programmed in this mode because it's a pressure mode. And then we'll skip one. We'll go over here to PEEP real quick. PEEP is going to be this whole section down here, giving me like a baseline pressure. And then I'll come over to PSV because that's what this one is about. And that's going to be these green waveforms right here. All of these green ones. And what you'll notice about them is that they can happen anytime, anywhere, for any duration, for any volume. So what happens here is you're going to have a baseline level of PEEP and then another level of PSV or pressure support ventilation on top of it. And so what you do is you measure the amount that they total. So I have like 5 and 5 here. So PEEP would be this 5 right here. PSV would be this 5 right up here. And so we would call that 10 over 5. But what does that sound like? That sounds just like BiPAP. That's because it actually is BiPAP. So whenever you're putting somebody into SimV, what you are doing is saying that, okay, I have this pre-programmed rate and inspiratory pressure, or you could even say tidal volume. Let's say that this was a volume SimV mode. And let's say that over here, instead of that blacked out 500, I had that highlighted and no inspiratory pressure. So those white lines up there were, 500 milliliters. It would basically still be the same thing. So I would be able to guarantee 20 per minute at a tidal volume of 500. And then anytime in between those breaths, or maybe even attached to those breaths, the patient could activate BiPAP. And you know how BiPAP works is it's just when they breathe in, it gives them some extra support. And that's exactly what PSV is. It's pressure support ventilation. And so it gives them the ability to breathe in slow, breathe in quick, take a shallow breath, take a really deep breath, or any combination thereof. So those were all the basic settings that I wanted to go over, and I will see you guys in section 3. Okay guys, welcome to section 3. So this is the part where I'm actually going to go through some of the finer points on how to use this ventilator resource that is actually found inside the critical care bags. This is also available in PDF, so hopefully you guys will keep this on your phones or tablets, whatever you guys keep with you on shift, and kind of study this because the resources are kind of hard to use if you're not really familiar with them. The time to use time to learn how to use a resource is not when you actually need it. It's way beforehand. So in a panic, you can figure out exactly where everything is, and what settings you have to change and stuff like that. So this is the front of it. This will be the back of it. And so we'll go over vent setups real quick. We're going to start by looking at the back of this thing. So this is kind of the same as before when we talked about tidal volume. You know, you're going to pick male or female. So check it out. You know, here you have a 5'4" female. Ideal body weight's going to be 54.7, and you're going to have a tidal volume 380. You know, maybe you use 7 cc's per kilogram. So, you know, 6 or 7. 6 would be ideal for lung protective strategy. 7 you would use if you had to, there was an actual need to move a little bit more tidal volume. And so when you set this thing in, you're going to look right up here. It says, if plateau pressures are above 30, decrease tidal volume by 1 cc per kilogram until a value of less than 30 is obtained. So that means that I'm going to go down and look at 6 then, because it just came back at 32. And so then I'm going to go ahead and use 330, which is 6 cc's per kilogram, and then make sure you're using the frequency that is associated with it as well. So then remember that those are just baseline frequencies. That's like your baseline respiratory rate that you should be using just as a basement floor. You may need to go over that, and we'll talk about that when we look at frequencies. So the next thing would be specific strategies. So there's lung injury and there's obstructive patients. So in lung injury patients, that's anybody who isn't obstructive. So their injury, they're defined as injury kind of by exclusion. If they're not a patient that tends to air trap, then they're injury. So that would be like the trauma patient, the patient who was intubated because of airway protection for a stroke, the overdose patient, the patient who has ARDS for sure, a lung injury patient. So you're going to use generally 6 cc's per kilogram. A normal IDE ratio, that's like 1 to 2, normally 1 to 2, 1 to 3. Maybe even a 1 to 1 sometimes, depending on their oxygenation status, but just make sure they're comfortable. Remember that faster flows are better for minimally sedated patients, and you do need, and watch your end-tidal CO2 if you need a longer expiratory time. So yeah, normally about 1 to 2. Frequency of approximately 20, because remember, you have a small tidal volume there, and so they're going to need more breaths per minute to blow off the CO2. And then for these ones, pretty strictly, you follow the FiO2 and PEEP chart. Now, if you have an obstructive patient, that would be somebody who has any kind of COPD, underlying asthma, stuff like that, you're going to use about 8 cc's per kilogram. Now, why is that? That is because you're going to give them a larger volume breath on the front end so that they can have longer to exhale. You're going to just jam in more tidal volume so that they can breathe less often per minute. I hope that makes sense. So the larger breath you give them, the less frequently they have to breathe. The less frequently they have to breathe, the longer their IDE ratio is. And because they air trap, that means they have longer time to get rid of that trapped air. So that's why it says longer IDE ratio right here. They get a minimum of a 1 to 4 IDE ratio. That means that their frequency, their respiratory rate, is usually about like 14, 15 per minute. They get more FiO2, less PEEP in bronchitis and asthma, but remember those emphysema patients, they might need a higher PEEP because their lungs are like trash bags, basically. So all respiratory rates are approximate. You're going to see why in a minute when we talk about frequency. And you really need to tailor your frequency to the CO2 elimination needs of each patient. And the actual formula that we use is based off of 120 milliliters of dead space. If you have a patient that has increased dead space, then you may need to increase that equation and use a higher frequency. So we're going to start at the top left here and kind of work our way down. So comfort, this is going to be that IDE ratio that we were looking at before. So these are the specific actual strategies now. So IDE ratio is 1 to 2, 1 to 3. And just keep in mind that even though the ratio might be okay, you want to look at the actual liters per minute because you might have to go down on them if the patient's uncomfortable, and you might have to go up on them if the patient isn't saturating well for certain reasons. Obstructive patients are longer IDE ratios, so 1 to 4, 1 to 5. And you always want to check those flow waveforms like we were looking at before when we were adjusting the IDE ratio to make sure that they're okay, to make sure that they're exhaling fully and that the flow stops. So if they're very difficult to oxygenate, consider inverse IDE ratios. That'll cause CO2 retention, difficulty with sedation, like we talked about before, and then deep sedation and then paralytics, never the other way around. Deep sedation and then paralytics may be needed. If you're going to use paralytics, make sure they're deeply sedated and that their pain is taken care of as well. So that means a sedative agent like propofol, Versed, along with an analgesic medication like fentanyl and ketamine. Ketamine can also serve both of those purposes, which is why we use it quite a bit. So ketamine can do sedation and analgesics, well, technically dissociation and analgesics. And then, but if you're using an agent like propofol, make sure that has no pain qualities to it at all. So make sure you're also using an analgesic like fentanyl or ketamine. So over here on the oxygenation side, goal of 94 to 99%, lowest FiO2 to accomplish that goal. And then here's that chart that we were looking at before. And then again, you might need lower PEEPs for people with asthma and bronchitis, but emphysema patients, they might require some PEEP. And then watch the map as well. Tidal volume, so that's going to be starting low, 6 cc's per kilo. If you come into a facility, you grab a patient that's already ventilated, and they have them on like some very large tidal volume, 10, 12 cc's per kilogram, and you come in and you're like, well, this is a lung injury patient, I got to go to 6 cc's per kilogram. You are correct that that is what current literature is telling us, that they should go down to 6, 7 cc's per kilogram. Even lower than that, 4 to 6 if they're an actual ARDS patient, and you have high plateau pressures, high driving pressures. But don't drop them extremely fast. If that patient is used to blowing off huge breaths at a certain time per minute, you want to slowly bring their frequency and their tidal volume where you need it to go. And so let's say that they're at 10 cc's per kilogram, you're trying to get them to 6, then you're going to maybe go down 1 cc per kilogram at a time while you slowly increase their respiratory rate. Don't make huge drastic changes and just drop them like a stone. They probably won't tolerate that very well, and you want to closely watch their end-tidal CO2 and their SpO2 while you're making these changes. Obstructive patients, we just talked about that, 8 cc's per kilogram and longer I/E ratios. Remember, if you give them a larger breath, they have to breathe less frequently. So plateau pressures should always be below 30, and driving pressures should be below 15. That plateau pressure, we watched a video of that before, I think in the first section. That's when we do that inspiratory hold, and then the driving pressure is that plateau pressure minus your PEEP. And so if you have a plateau pressure of 30, but you only have a PEEP of 5, that might look okay at first. So you're thinking, oh, good, I'm below 30 on my plateau pressure, but that would equal a driving pressure of 25, and that's really, really bad. Basically, what that means is you are actively murdering this patient with every ventilation. I was just reading my wife's respiratory book that she has. She's in RT school, and there's a section there about ARDS, and it says that with like extreme tidal volumes, or let's say you push a lot of volume into a very incompliant lungs, it says that 6 ventilations of inappropriate tidal volume can be enough to cause ARDS, which is crazy. It can be a very short amount of time to cause tears to those lungs, micro tears, cause an inflammatory response, and then just really alter that patient's course from there on out. So if you have a plateau pressure of 28 and 15, well, that driving pressure would be like 13 then. So at times you may see, like, it might not seem like it, but if you look at that plateau pressure and PEEP up top, 30 and 5, it might not seem like you could get the driving pressure. It might not make sense that like a plateau pressure would come down and you add pressure to it. But if you think about surface area of lungs, it starts to make sense, because if you have a very small portion of lung that you're working with and you're trying to squeeze a certain tidal volume in there, what you may have to do is just increase the PEEP, and that might drastically increase the amount of surface area that you're working with in the lungs, and that by itself will give you enough room for the tidal volume that you're trying to put in. So by increasing the PEEP, you can actually lower your plateau pressure and your driving pressure simultaneously. Conversely, if you raise your PEEP, and your plateau pressure goes up with it, almost in tandem. Like you raise your PEEP by 10, plateau pressure goes up by like 8, 9, 10. That's not good. That means you're working with pretty much as much lung as you can get, and what you're going to have to do is go really low on your tidal volume. And that's a very, very sick patient. Next thing is ventilation. So that's going to be our frequency. And so when you have a problem with CO2, you're always going to be looking at this setting. Winter's formula and target end tidal CO2 with frequency is two things that are found on here that are really important. This first thing up here where it says lung injury and obstructive patients, it says ideal body weight times 120 divided by tidal volume equals frequency. So that's basically ideal body weight times dead space divided by the tidal volume we're using is where we get our starting frequencies. That's where we come up with respiratory rates as a whole. The reason I put that on there is if you have different formulas that you need to work with, then you can start from scratch and figure out the appropriate rate for your patient. So for metabolic acidosis, it says use Winter's formula. So here's the formula. It says for every 1 the bicarb is lowered from 24, aim for a PCO2/end tidal CO2 to be 1 lower than 40. So for an example, an HCO3 of 14, target a PCO2 of 30. So I'll draw that out in just a second. We'll keep that in mind. And then to obtain appropriate frequency for target end tidal CO2, you take your current end tidal CO2 times your current frequency. So let's say your current end tidal CO2 is 50, respiratory rate's 20, so you do like 50 times 20, and you want it to be 40, divided by 40 to give you your corrected frequency. And that kind of goes hand in hand with that Winter's formula, because if you know where you want your PCO2, the second formula helps you determine what respiratory rate you need to get there. So here's how you come up with those numbers for the Winter's formula. So an average bicarb, or like if you look at most hospitals' lab panels, it'll be 22 to 26. So that's an average of 24, right? That's right in between those two numbers. So we use an average of 24. And then for the PCO2, we use an average of 40 because it's halfway between 35 and 45. And so if we have this ABG right here, we got a pH of 7.1, HCO3 of 10, PCO2 like 38, then we're like 14 below average right here. And this is only 2 below average. And so for proper compensation here, the PCO2 should be about 26 for proper compensation, because that HCO3 is 14 below, and so if you take 14 off of like 40, which is the average that we're using, 10 less would be 30, and then 4 more off of that would be 26. And so you'd be looking for about an end tidal of in the mid-20s, mid to high 20s for this patient for proper compensation. And then so now that you know what your target PCO2 or end tidal CO2, if they're close, should be, then you use this second formula and you say, okay, my current end tidal CO2 is 36, or 38, sorry. Times 20 is my current rate, and I'm going to divide that by 26, and that's going to give me 29, which is my new corrected frequency. And use like a stepwise approach. And so if you're at 22, you're going to check the IDE ratio. Let's say you go from 20 to 22. Check the IDE ratio, adjust your flow if you have to, check for any air trapping in the waveform, and then just keep repeating that and just go up little bit by little bit. 22 to 24, check everything. 26, check everything. 28, check everything. 29, check everything. And you just don't want to do these giant changes on the ventilator. You want to do incremental changes working towards a goal, and then you want to see how the patient actually reacts to that. All right, guys, that's all I had for this section. I'll see you in section 4.
All right, guys, so this is going to be the last section here, and we're going to talk about different modes. So we're going to jump right into it. The first mode that we're going to talk about is going to be volume AC. Volume AC, or volume assist control, or in the hospital, most people call it ACVC. So when we look at volume assist control, this is like the most basic mode of ventilation that our vent offers. It's very close to what we used to have on the very most basic ventilators, where it's just rate, tidal volume, and FiO2. This adds PEEP. It adds, variable flow with the I to E ratio and things like that. And then what assist is, because used to be able to just have volume control. And that just meant the only thing that patient was getting was exactly what you have programmed in. Assist, it takes the patient's own spontaneous assistance or spontaneous rate or spontaneous effort is what I'm trying to say, and then gives them that volume again. So in these modes, it's very nice because you are guaranteed a tidal volume. So when I put in, on the screen here, 12 and 500, I know that I'm going to get 12 breaths a minute at 500, unless the limb falls off the patient, unless, the peak pressures start going off, it stops ventilating, something like that happens. I know I'm guaranteed that minute volume. And if the patient decides to take a spontaneous breath in between those 12 breaths, it's going to give that 500 again. So that's what assist and control is. Control is just those 12 at 500. Assist is it's going to give the same breath again if the patient decides to take a spontaneous breath. So assist control is not a bad mode. It's what 95% of the people that we transport are on. But what are some of the downfalls of it? Not all patients tolerate this mode very well, especially if they're lately sedated. If they want to take some of their own breaths, if they have spontaneous breaths that they're taking, they may not want to be hammered with that 500 all over again. They may want a breath that's more tailored to them. And that's where we get into mode 2 over here, which is EnVe volume, which is synchronized intermittent mandatory ventilation. And so let's look at the last two letters there, mandatory ventilation. So if we just took those, it'd be EnVe volume. And so what that means is if we look at this mode again, we have a rate of 12 and a volume of 500. So that's the mandatory ventilation portion of this. You're guaranteed that minute volume again because it's a volume mode. So what does synchronized intermittent mean? That means that intermittently, if they take a breath, it's going to synchronize with their flow and rate. And so like we talked about before, if you remember, it puts them into BiPAP. So it's going to give you those 12 and 500 no matter what. But if they take a spontaneous breath, it's going to basically give them BiPAP assistance. It's the exact same thing. So it does that pressure support breath or pressure support ventilation. That PSV is now lit up on that screen. And so it'll ventilate them, assist them in ventilating at 10 centimeters of water pressure above your PEEP. So what are some of the downsides to this mode? Not all patients that are spontaneously breathing like this mode. So let's say that you're transporting a patient and they're in AC volume and they're very reliant on their spontaneous breaths. And all they want to do is they want to trigger the vent and rely on it to give them that 500. Well, if you go ahead and you switch that patient because you see that they're taking spontaneous breaths and you think, oh, they might be a little bit more comfortable on EnVe volume because I've heard that spontaneously breathing patients, they're breathing on their own, they like EnVe. So you switch them to EnVe and they don't actually have the inspiratory capacity. They don't have the diaphragmatic strength. They don't have the cognitive ability right now to do a sustained inhalation. All they have strength to do is just gasp for air and rely on the vent. Well, if you put them in EnVe volume, then they're not going to really get any assistance spontaneously at all because PSV relies on them to be consistently inhaling. It only assists them during the time of inhalation. Whereas if you had a triggered assist breath like an AC volume, all you'd have to do is gasp in and it would hit them with 500. So it doesn't work for all spontaneously breathing patients, but this is an option for patients who are pretty vigorous and not very, they are not synchronizing with the ventilator very well. So they probably need like a decreased eye time, more sedation, analgesics, and maybe switching to EnVe volume. Mode number 3 is going to be pressure AC or pressure assist control, otherwise known as ACPC. So this one is exactly like volume AC, except you're replacing the volume breath with a pressure breath. And you can see that you cannot set a volume in this mode. So what do you do if you can't set a volume? Well, you set a pressure. So This defaults to 15 centimeters of water pressure. So that means 12 times a minute, you're going to get, the ventilator is just going to say, I'm just going to give 15 of inspiratory pressure, and whatever that gets me, it gets me. And then it's up to you as the clinician to decide, is that enough pressure or is that not enough pressure? And how are you going to decide that? Well, you want at least 75% of your target tidal volume. So let's say that I have a target tidal volume of 500. I want 75% of that back, and so I look at up in my tidal volume exhaled, which is my VTE up there on the top right of the ventilator. If you can see the number that says 431, and then the one to the right of it is 4.6. That's your minute volume. So there's a saying that when you're in a volume control mode, monitor pressure. That's where we get our plateau pressures, our driving pressures from. When you're in a pressure control mode, you monitor volumes. So when you're giving just a pressure, you have to make sure you're physically getting back enough volume. And so you're always looking at your tidal volumes exhaled and your minute volumes. So make sure you always document those. SimV pressure, you can probably see where this is going. So synchronized intermittent mandatory ventilation, but in a pressure mode. So this is going to have a lot of lights lit up here. So you have a rate. That's going to give the inspiratory pressure at a certain time per minute. So, 12 times per minute, you get an inspiratory pressure of 15. But when they take a spontaneous breath, it's going to give them that BiPAP again. It's going to give them PSV, 10 centimeters of water pressure above 6. And so that would be like 16 over 6. It would basically give them when they spontaneously breathe. So mode 5 is going to be, so we're moving into the non-invasive modes right now. So this would be like if somebody was wearing a BiPAP mask. So NPPV, CPAP / PSV. Everybody probably already knows this, but BiPAP is a trade name. And so only a certain brand can use the term BiPAP, and everybody else just uses it. It's kind of like Kleenex for, tissue papers or whatever else you can think of. It's just a very common brand name. So what NPPV is non-invasive positive pressure ventilation. So that means this patient does not have an endotracheal tube. Continuous positive airway pressure, CPAP, that one's easy, / PSV. So remember our pressure support ventilation? That's how we came up with BiPAP. And this one's interesting. So you're going to see this is a spontaneously breathing mode. Look, the rate isn't lit up, the volume, the inspiratory pressure, the pressure trigger, or the inspiratory time, nothing like that, right? So basically you have a PEEP, that's the most basic setting there, and then a % of oxygen, and then since they can trigger the vent, you have their flow trigger, and then you have the PSV lit up. And remember that is the number above PEEP is going to be your IPAP. So if you go in for a patient and they're on BiPAP and they say, well, the patient's on 10 over 5, they're doing really well. Well, what are you going to set them at? Well, your PEEP would be set to 5 and your PSV would be set to 5 as well, because remember, it's the number over PEEP. So you add those two together, you get 10, and then 5 is your EPAP. So right now, when you look at the ventilator, you might think that it's at 10 over 6. It's not. It's at 16 over 6. So remember that it's additive, not absolute values. And the last one that we're going to talk about is called NPPV pressure. So when you're in the non-invasive mode, when you click onto mode, you can turn it once to the left, it goes to NPPV pressure. And again, this is non-invasive positive pressure ventilation, but this time you're going to get inspiratory pressure with this mode. This is a very interesting mode. So you can see over here, this looks a lot more like a intubated mode of ventilation, but it's for the non-invasive mask. So over here, I have a rate again. I have a rate of 12 programmed. I have an inspiratory time again. I have an inspiratory pressure. And remember, the inspiratory pressure, it's different than the PSV. So the inspiratory pressure, all they have to do is trigger the ventilator, which we have our flow trigger lit up there, and it will ventilate up until the vent reaches that pressure. And whether or not they trigger that or not, it will give it to them 12 times per minute or whatever you set. And then they have over here the PEEP again and an FiO2. And so why is this mode next to the BiPAP? Well, if you're a patient, let's say you're transporting somebody and they're on BiPAP and they're not doing very well. They don't have a lot of respiratory effort, and you start to think like, man, they're not breathing very fast anymore. It's kind of like having somebody on CPAP. Like I can't program in a rate. I can't make them breathe any faster. I can make them breathe harder. I can't make them breathe any faster. And so what you want to do is you want to take away that person's, you want to take away their, not their respiratory drive, but all their respiratory effort. And so you want to take over more control, give them more support, breathe faster for them. And so how would you normally do that? Let's say you had a patient on CPAP and you don't have a ventilator. If you had a patient on CPAP, they're breathing too slow, they're not breathing deep enough, you would take out the BVM, you take off the CPAP attachment, put the BVM with a PEEP valve on the end of the CPAP mask, and you'd breathe for them, right? That's exactly what this mode is. So NPPV pressure, you can basically think about it as a bag valve mask. That's exactly what it is. So when your patient is failing BiPAP, or let's say that you're just putting somebody on non-invasive at first anyway, or you want to use this as a bag valve mask, you can do that. This is pretty much a bag valve mask setting. So that is all I wanted to cover in the ventilation modes, and that is the end of section 4.